Welcome to Markets Plus, where leading experts from across BMO discuss factors shaping the markets, economy, industry sectors, and much more. Visit bmocm.com/Markets Plus for more episodes. The views expressed here are those of the participants and not those of BMO Capital Markets, its affiliates, or subsidiaries.
During our second annual BMO Obesity Summit in New York, Evan Seigerman, Managing Director and Senior Research Analyst at BMO Capital Markets, sat down with two leaders in the obesity medicine field, Sloan Saunders, CEO and co-founder of FlyteHealth, and Dr. Leon Igel, Chief Medical Officer of FlyteHealth. Listen in on their conversation surrounding the growing innovation in the obesity medicine space.
Welcome back to BMO's second annual Obesity Summit. So we're going to shift gears to care delivery. And to talk about care delivery, we have Sloan Saunders, co-founder and CEO of FlyteHealth, and Leon Igel, Chief Medical Officer of FlyteHealth. I'm so glad to have both of you here today because you're really innovating and helping improve access for patients that need care in the obesity space. Before we jump in, maybe just tell us a little bit about what FlyteHealth is, what IntelliHealth is, for those that are not familiar. I know we talk a lot about it, but what was the goal of the platform? What is the goal? What patients are you serving? And kind of what traction have you gotten? Maybe Sloan, start off.
So Catherine and I, my wife, started FlyteHealth with our co-founder, Dr. Louis Aroni, around 8 years ago. The mission has always been to democratize access to cost-effective medical weight management care. In essence, we're a tech-enabled services company. Foundationally, from a technology perspective, the goal has always been to enable our providers, but also other providers that we work with, health systems, other risk-bearing provider groups. And really, it's anybody who needs clinical care for weight and the related conditions, whether it be hypertension, hyperlipidemia, diabetes. And we're fortunate to work with large self-insured entities like the state of Connecticut, to health systems like Emory, New York Presbyterian, and other medium and large and small employers.
And I guess in creating FlyteHealth, what were you trying to solve for? Either from, patient experience side or, even a clinical side.
Foundationally, my background has always been on the finance investment side. And one of the things that really fascinated me as Catherine started to do her fellowship training in this clinical area was a classic supply-demand mismatch. So she was the first clinical fellow in obesity medicine at Weill Cornell. At that time, obesity was a very prevalent condition afflicting about 70 to 75% of the US population. Those two lines will never intersect. And so how we actually are able to bridge that chasm is leveraging technology and empowering other providers to think about integrating and optimizing that integration within their clinical workflows as it relates to other existing care pathways.
Excellent. And maybe Leon, what are you trying to solve in terms of the patient experience or kind of delivering care with Flight?
Yeah, so I think we want to take all of the positives from an academic environment and be able to scale that to a 50-state platform, but also recognizing that there is just a limitation to the number of clinicians today who truly understand how to manage obesity effectively. Having run the Obesity Medicine Fellowship at Weill Cornell prior to coming over to Flight, we recognize that even at best, we were able to take a handful of providers and train them in the way that was necessary. Most residencies, most fellowships really don't touch on obesity management at all, despite the fact that, as Sloan mentioned, there's 75% of the US population who's dealing with obesity. So you have this just huge mismatch. And even those who sit for the American Board of Obesity Medicine board certification, right now that's a CME pathway. So most clinicians who have knowledge in that area, they essentially are learning it from a conference, sit for that. They say they're board certified at that point, but they really have had no clinical care capabilities at that point, and they're still searching for, well, how do I actually apply this in practice? So we tried to take all of those pieces, recognizing the shortages in clinicians, shortages in the general field, and take the training, build it into a software platform for our clinicians so that we could bolster the underlying clinical services arm and provide that training at scale.
And how have you seen, aside from GLP-1s, which we all know, how have you seen the treatment paradigm evolve for patients living with obesity over the past 2 years? And then, the question for you, Sloan, is, how does Flight enable that treatment?
I think it's interesting because if you ask most people, they think GLP-1s came onto the market like 3 years ago, because that's when social media decided to actually start talking about it. But we've been treating with GLP-1s since 2005. So the first GLP-1s were released 20 years ago, and we've been using them for years and years and years. We were focusing on the weight-centric management of type 2 diabetes when everyone else was focusing on the glucose-centric management of type 2 diabetes and really just focusing on A1C targets. So it was a very different landscape that we were kind of coming into. But yes, the GLP-1s have definitely changed the landscape. Part of what we still think is very important, though, is recognizing that for many payers, many self-insured entities, that cost is still a very big concern. And so how do you navigate that? How do you still use many of the other medications in tandem with the GLP-1s to bring down the cost, spend, and average across the board? And recognizing that for many people, a GLP-1 is fantastic, but it may not get them the full amount of weight loss that they need. So it's tying in the other agents that may actually work in combination with those agents to really get the 30, 35, 40% body weight loss that some people actually necessitate, or for those who don't respond to GLP-1s.
And so the opportunity for us, to your question, is to really prove it, right? So what we built from an infrastructure perspective is the ability to actually identify the patients who need care, use technology to optimize what care is being delivered and how it's being delivered, measure and deliver that care throughout a long, holistic journey, and then actually publish on the data, both from a health outcomes perspective, but for us as an organization, a lot of our clients are risk-bearing organizations that have to foot the bill. And so really refining and quantifying what that return on investment or economic impact actually is our holy grail that we're actually starting to publish on with some organizations as it relates to correlating our health outcomes with pharmacy and PBM data, medical claims data, and optimizing that sort of care journey throughout.
And maybe walk me through the typical experience of a new patient coming onto your platform. What does that onboarding look like? And how do you make decisions as to what they need?
Yeah, so I think that's probably the core of the art and science of doing this job in general, is taking all of that data and distilling into exactly that, what each person is going to need and individualizing that care. So when someone comes into our system, they start out to get a broad set of metabolic labs. They fill out our HRA, which is a set of questions that, kind of help to clarify a number of facets of that individual's background, their weight history, their sleep history, their food patterns, their cravings, their appetite, all of the pieces that we want to know so that we can essentially phenotype out what each person's underlying distillation looks like. And we also look at things like obesogenic medications that can actually contribute to weight gain or limit weight loss. And all of those pieces together allow us to start to determine, okay, does someone have an excessive appetite? Maybe in that circumstance, a GLP-1 is the right choice. Does someone have underlying diabetes and another indication as to why that would be the case? But for a lot of the other medications, there are, stronger medications sometimes for binge eating, for cravings, for night eating, for all these other components that we can then target specifically with other medications that may cost far less. So there is that balancing act between the two, and also recognizing that combination therapy is quite often necessary. So it may not be just one generic medication that needs to be used. It may be 2, 3 medications together.
And as you think about kind of the ever-evolving needs of a current patient living with obesity, what is current state-of-the-art able to address? And what are some of the opportunities and still needs that are out there, with potentially newer medications? Is it different routes of administration, longer acting, higher efficacy, different parameters you're looking at?
Yeah, I think the future's really interesting when we look at the pipeline, because I think as we start to have agents that spare muscle, as we start to look at agents that have longer half-lives, as you mentioned, so that administration is now monthly instead of weekly or even longer, I think we're going to start to see also that as secondary indications come into play. So the way we're starting to see some of the existing agents have approval for use in sleep apnea or heart disease or whatever it may be, as we start to expand that out into NAFLD and NASH, or MASLD and MASH, whichever one you want to use, or into other, very key areas of existing disease states, that is something that I think as we have those secondary indications, I think that's going to change the landscape as we go forward.
And as you think about kind of the health economic outcomes, what are you seeing? I know you're going to publish this data, but what are some of the additional early trends that you're seeing through this data that you're amassing that's helping convince some of these payers, aka employers, to open up access for the right patients?
Yeah, it is a tricky line to navigate. Payback period continues to be, a big question mark for a lot. A lot of our, economic value for the state and our other clients have come on the front end in terms of cost avoidance. So, if you look to sort of real world outcomes, it's unfortunately a very sort of, I wouldn't say dire, but, not as attractive of a scenario. Very poor adherence, not great outcomes for a large population. Under our pathway, we do see 3x adherence, north of 15, almost 20% weight loss on an average basis. And that's including a lot of the older agents. And really where we see opportunities to correlate that data with their claims, both on the pharmacy and medical claim side, is really helping to optimize what that journey looks like for the patient and surround them with that ecosystem of support. So one of the things that you mentioned before in terms of the related conditions is a lot of initiatives that we're actually taking as it relates to women's health, a pre-post surgical program, GI, and I think we are novel in this. We launched our Medicare program with state retirees north of a year ago. So we have great data from that population. It's a unique Medicare program where the state is providing a supplemental benefit for coverage of GLP-1 drugs. So we are getting some good real world evidence in an older population.
Where does the GLP-1 fit in kind of that treatment paradigm? What do you see in a patient archetype says, yes, you are the right candidate for that? Have they failed something? Are they, BMI of 30? They have tried a lot. They can't, make any progress. What makes that determination in your mind for someone who is best suited?
So we certainly will use GLP-1s first line in a very, kind of clear subset. So, those with diabetes, that's an obvious frontline choice. Those with advanced heart disease, sleep apnea, those with higher BMIs, all of those things really lend themselves to using GLP-1 earlier on when you know they have comorbidities that are more likely to resolve in those sets of circumstances, and that the weight loss that's necessary to achieve comorbidity resolution is going to be at a higher threshold. Whereas if someone's coming in with a BMI of 27 and high cholesterol, I can get their weight normal with many of the other agents that don't really require the bazooka of the GLP-1. They're very strong agents. And to lower someone's BMI, I don't need to do that if they're only starting at a BMI of 27, for example.
Right. And, as you think about kind of what's next on the horizon, we had a few, that was part of the conversation earlier. What excites you most and what do you think is going to add more strain to the system? What are people going to want more of?
I mean, the agents that we're seeing that start to hit multiple agonists, that hit different mechanisms that, tie these things together, I think the inevitability is that as you start having agents that, again, exceed bariatric surgery weight losses and have lower side effect profiles and have greater efficacy and have longer half-lives, as we get to those points, it's going to be very hard to both not use them because they're going to be very much in demand, and the greater number of anti-obesity medications that come onto the market, I think you're going to need more and more clinicians to actually have comfort in treating with those agents. So I think right now we have an undersupply of folks who feel comfortable and have the time and the bandwidth to not just say, here's your medication, but actually provide all of the behavioral and lifestyle counseling along with the prescription. We have so many people who get prescribed an agent now and they get told, oh, you have a weight issue, here's your medication, best of luck. Hopefully it's working by the time you come back in, but it's really just being used as an agent by itself with no other programmatic care around it. So I view the future of this as being one where the stronger agents, the more sort of comprehensive care is going to have to come together, and we're going to need more and more people trained who can do this effectively and efficiently.
Aside from software platforms, how do you scale this? Because we do have a shortage of, clinicians and providers who are trained to effectively treat patients with obesity. We have a lot of patients living with obesity. So how do we kind of solve for that supply-demand mismatch outside of just supplying more GLP-1s to the market? Sloan?
A lot of what Leon has touched on, is where we're leveraging technology to not only enable other clinicians who might not be specialists, but in optimizing that care model. for us, where we see, the largest opportunity to not only get the adoption of new therapeutics into the market, but is really the value proposition to those risk-bearing organizations is essentially a risk mitigation opportunity, right? The reason why a lot of these organizations are uncomfortable covering these medications is they don't see the payback. They're not sure if they're actually going to, reap the benefits of that. So to the extent that we can provide them comfort and guidance and transparency around that this investment now is actually going to pay the dividends down the road, but what are those dividends, and optimize that and even maybe secure that, is the true opportunity we see working with these, risk-bearing organizations to implement these pathways.
And, what does that payback look like? Is it 5 years? Is it 3 years? Like if you start a patient on a GLP-1 and they stay on consistently, when do you start to see that payback in terms of their health outcomes?
I think that's the $1 trillion question.
$1 trillion question at this point?
I think, for us, and this is, some of the research that we're getting ready to publish, if you look to sort of real world outcomes, the people that are actually getting a GLP-1 are the lower acuity segments. But under our pathway, we've optimized, those protocols for a very personalized nature of that population. So based on acuity, based on the complexity, leveraging these more cost-effective interventions. So in our minds, if we think about sort of that as the infrastructure layer in that ecosystem, right, that's the payback that we're trying to really optimize. It's not, for us, one therapeutic having an ROI of, 2.5 years, but it's making an investment in an ecosystem, and the blended average of that ecosystem has a payback period of X, and are able to actually shore up and take risk against that ecosystem is where we see the nearest term surety in that ability to buy.
And what is the future of obesity care? Is it telehealth platforms, Gen AI? Is it primary care physicians prescribing small molecules, a combination thereof? Looking into the future, I know that's fraught with plenty of issues, but where are we going?
I think it's a combination of all.
Okay.
I don't think it's, one or the other. I think, for us, the future of healthcare is a hybrid model. We've already started to deploy, what we call our brick and mortar pathways with partner organizations. We're doing that with the state. So the phase 1 program with the state was just our providers in a virtual setting. We are now working with a few health systems in Connecticut to deploy our protocols and pathways using our technology within their provider groups. We've done that with Emory as well, and Christiana Care, and we're launching with Kaiser Permanente to really create a more holistic ecosystem that is able to surround that patient both from an in-person setting and also a virtual setting. We are obviously big believers that technology plays a huge component in that optimization of patient journey, but also that clinical decision support. And then again, the inverse of that is the economics and optimizing that throughout.
And I guess, what does the patient journey look like in this more idealized world? Like, what would you hope a patient would experience, and how do we get there? Leon, maybe thoughts on that?
I mean, ideally, if we can remove many of the roadblocks that are limiting access to medications, that are making medications as expensive as they are, both for the folks who have to pay for them and in many cases the patient directly, it has become where the expectation to some degree, especially with obesity specifically, is that the patient themselves has to foot the bill. And that's really not the case in many other disease states, right? You don't expect that in hypertension or cardiovascular disease. People aren't paying for their PCSK9 agents out of pocket, right? It's a very different worldview, and there's still a bit of bias and stigma around obesity that the expectation is that somehow this has been their fault and therefore they have to do the work. I don't know how to change that underlying bias, because I think that has to change across the board. It's the same reason why Medicare at the moment says, this is a lifestyle disease and therefore we're not paying for it. Obviously, they've started to expand some of that when they say, well, now if you have heart disease underlying, well, maybe we'll pay for it then. But the entire infrastructure around how obesity is viewed has to change for coverage to change at the same time. So I view that as kind of like the first step towards the appropriate patient journey. And then as we start to improve those pieces, the stigma lifts and the coverage improves, and then folks can actually get the access and care that they need.
Excellent. And as we think about kind of the future of the obesity care space, what do you hope happens in the next 5 years in terms of access, in terms of new drugs, in terms of, reducing the stigma? I guess leave us on kind of a high note. What are you hopeful about when it comes to this space, Sloan?
I would say, for us as an organization, it's all of it. Dr. Kaplan, one of our advisors, continues to tell us that this is the most expensive obesity care will ever be. I think when we think about cost, we think about not only our clinical services, but also the cost of the medications. And so optimizing that entire cost structure to understand what that inverse is and that economic benefit is where we need to go as an organization, but also as a society. And I think with that comes that rationalization and that understanding of best-in-class ways to treat, but also the applicability to the different populations who need that care and to what framework that care is being delivered. That, is a requirement for us to actually get out of the situation we're currently in.
To everything Sloan said, and I just think that the efficacy of the agents, again, as they continue to expand, as the mechanisms expand, so again, more oral options, as well as more injectable options as the half-lives expand, I think we're already excited what we have in the field, and we know that the pipeline is vast. So it's a really amazing time to be in this space and seeing what's potentially coming down the pipe right now, to recognize that we're going to have all of these things to treat in short order. So it's a really exciting time, and I'm incredibly optimistic, because if we're having the success that we're having now with the small number of options that are on the market, expand that, double it, triple it, and then, let's see what the space looks like. I would love to be able to say that many of the surgical options are no longer necessary, or if they are necessary, they're being augmented in a way that the agents are being used before surgery, after surgery, to get folks to those optimal conditions, so that even like the more advanced surgeries are not necessary, and you can have some of the simpler approaches used more confidently, because those agents will augment the outcome. So again, it's a really interesting time to be in the space, and a really optimistic one as well.
Excellent. And with that, we are out of time. Thank you, Sloan. Thank you, Leon.
Thanks for listening. You can follow this podcast on Apple Podcasts, Spotify, or your favorite podcast app. For more episodes, visit bmocm.com/marketsplus.
For BMO disclosures, please visit bmocm.com/podcast/disclaimer.